Thank you very much for the invitation to speak today. I'm pleased to be here to talk about some of our successes and challenges in using simulation over the last stormy 21 months of the pandemic. Um, Today, I'll be describing a framework for making choices and sacrifices in medical education during a pandemic. I'll explain the application of this framework within the context of simulation-based education, and I'll list some of the successes and challenges encountered while delivering simulation-based education in the context of pandemic-induced program modifications. So let me take you back to 2020. The World Health Organization declared the outbreak a public emergency of international concern on January 30th and a pandemic on March 11th, 2020. That evening, I had been scanning the news from states of emergency in Italy and New York City and looking up PPE recommendations. And I was thinking that I should be organizing some simulation sessions to prepare our staff. I did not think that the next night on March 12th at 1 o'clock in the morning, I would be intubating the first potentially COVID positive patient in Ottawa, Canada, a woman with an acute abdomen coming for emergency exploratory laparotomy who had returned 2 days earlier from New York City and had symptoms of a fever and a cough. It was a bit of a blur. I knew I needed to glove and gown and wear goggles and an N95 mask. I knew we needed to intubate in a negative pressure environment. I remembered something about concerns about the lack of neck protection with PPE, and I'd read about doffing and donning, but I hadn't done it for what seems like a very, very long time. Long story short, I wore way too much PPE. Along with the gloves and double gloving and a gown, I wore my glasses, goggles, a face shield. I wrapped a plastic bag around my neck, which turned into an instant sauna, and I did not doff before transferring the patient from the emergency room to the operating room. I remember the entire operating room team was stressed. We kept our trainees out of the case, and post-operatively, I kept the patient intubated in ICU because we were unsure as to how to safely extubate the patient. To say that we were unprepared was an understatement. The practice-changing implications of the pandemic were only just beginning, and the explosion in literature to follow was staggering. In fact, if you search since that date for the keywords of simulation and pandemic in PubMed, you will get 4,593 results, 90% of them, over 90% of them since 2020. And if you search the keywords of simulation and COVID, you get over 6,286 results, all since 2020. We are in the midst of a global health crisis, but as Albert Einstein said, in the midst of every crisis lies great opportunity. The use of simulation has been integral to the ability of healthcare personnel and healthcare systems to rapidly respond to the crisis. This paper by my colleagues in Alberta, Canada, is but one example of what we have learned and gained. But I think you will agree that our learners have been equally impacted as much as our patients and colleagues. For them, all formal education activities came to a screeching halt when the pandemic was declared, yet they still needed to learn and progress in their training. So how do we make these choices in education, and what sacrifices do we make? This paper was a collaboration between educators in Denmark, Singapore, New Zealand, and Canada, and in it, they outline a framework for making these difficult choices and sacrifices. The table in this paper summarizes the considerations for making these decisions. It is quite difficult to interpret and read in a short period of time, so I've taken the liberty of simplifying it for you. Essentially, what they are asking is, what do we continue intact no matter what? What do we postpone but can still happen as is? What do we need to adapt or change or run in a different way? What can be dropped completely? And what needs to be added? And for all of these 5 areas, to continue, postpone, adapt, drop, and add, we need to determine how exactly to enact them, the impact of doing so. We need to determine the options and the opportunities and constraints of doing it, and we need to consider what worked, what didn't work, and what can we learn. What I'd like to focus on next is the impact of using this framework on simulation educator obligations and responsibilities within the first initial phase of the pandemic in Ottawa, which basically lasted from March to August of 2020. This is an overall summary here of what we decided to continue, summative assessment, postpone our formative assessment, adapt, simulation implementation and debriefing. We dropped our trainee interprofessional simulation and we added faculty interprofessional in situ simulation. So I will outline some of the challenges we faced, some of the surprising opportunities that arose, and how our nimbleness has changed our educational practice. So I'll start first with what we added, and that was interprofessional in situ faculty simulation. And as you know, at the beginning of the pandemic, there was an onslaught of change in almost every aspect of how we took care of our patients in the operating room environment. We needed to provide opportunities for our staff to practice, working in different locations, wearing uncomfortable and time-intensive PPE equipment that made it difficult to see each other, the patient, hear each other, hear the patient, hear our monitors, and all in performing a different sequence of actions using new surgical site checklists, new airway cognitive aids. Absolutely nothing was the same as before. And what we needed to focus on were the foundational aspects of our everyday practice. We needed to pull this together fast. We needed to do it well. And since the Ottawa Hospital is one of the largest tertiary care hospitals in Canada, 1,200 beds, we needed mass delivery. And like Everest, the logistics were a massive undertaking. Normally, when we run simulation programs, we meet with stakeholders over weeks to months prior to implementation. We determine our educational needs assessments, we develop the scenarios, we ensure we have all of the proper equipment ready, and we do a practice dry run of every scenario with all our stakeholders present, and we work out all the kinks before actually delivering the curriculum. With our rapid response pandemic readiness training, we created the protocols for the surgical safety checklist, our airway cognitive aids. We created new operating room standard operating procedures. We developed the scenarios. We did not do a dry run, and we delivered the entire initiative within 4 days, basically over the weekend after Canada closed its borders in March. So like Everest, it was a massive undertaking. It involved a massive amount of people, and it was a big push at the end. The IPAC and PPE training began 3 days after we mobilized. Simulation training launched 2 days after that, and it took into account our constantly evolving infection control protocols, airway management, checklist protocols, and perioperative patient flow. We ran 2 scenarios initially, the stable COVID positive patient presenting to the operating room for emergency surgery, and an unstable COVID positive patient requiring urgent intubation in a remote emergency department isolation room. With successes of this endeavor, well, we trained 150 staff in PPE donning and doffing procedures over 2 days. We ran 239 staff who participated in the simulation over 3 days, 100 anesthesiologists, staff residents and fellows, 34 surgeons, staff residents and fellows, 106 additional healthcare workers, including nurses, anesthesia assistants, and operating room attendants. The feedback from the participants was very positive, and better yet, I was able to generate an extensive list of crowdsourced suggestions for improving the working environment and protocols to feed forward to hospital senior management. Training at both sites of the Ottawa Hospital perioperative staff were completed 7 days after we initially met. However, there was a challenge, an unexpected consequence to our mass delivery of simulation training to our colleagues. The 4 days after simulation training, our simulation educators were informed by the Hospital Occupational Health and Safety Administration office that one of the simulation participants was being tested for COVID. All healthcare workers who came into contact with that individual needed to be risk stratified by the Occupational Health Office according to the time that was spent in close proximity, the type of interaction with the index participant, and they were given instructions on how to proceed, whether that be self-monitoring, self-isolation, etc. And because of the Personal Health Protection Act, No details of the participant, their symptomatology, the reason for testing, or outcomes of contact tracing were disclosed to us. And as you can imagine, this caused a great deal of distress amongst the affected staff, in addition to the impact on staffing in the operating room in the hospital. Now, as far as I know, the tests all came back negative with no transmission between individuals. However, the risks to simulation participants have rarely been reported. And when they have, they've been focused on psychological safety mostly. The usual risks to healthcare workers during training during simulation are most often limited to that, and there's been very little reports of physical health risks. So we wrote a paper on this, and if anyone is interested on our suggestions on mitigating the risk of virus transmission during sim-based pandemic readiness training, we've summarized them here in a table, which you can access by this QR code. So we subsequently pivoted to the creation of 360-degree spherical virtual reality training videos of these scenarios. And here I just want to show you an example of one of our 360-degree videos. This is a still shot. I'll show you how to access these videos in a moment. But this particular situation is how to do a tracheostomy on an awake COVID positive patient. And the insert in the top left corner is the overhead view of the surgical procedure itself, while the main screen is a view of the surgeon, the anesthesiologist, and the assist. The arrows on the top right corner show how you can move the video in a 360-degree fashion using the arrow keys on your keyboard, but the easier way to do that is usually using a mouse. And the videos can be viewed on your phone, on your laptop, or on a VR headset if you own one. And these training videos, along with others that we created, are freely accessible to anyone who wants to view them. So we eventually made 17 videos of various clinical procedures, and some of the topics are shown here. And you can access this via the QR code. So now on to some of the other choices and sacrifices that we made. So what I'd like to focus on is what we continued, postponed, and adapted, and I will, continue, postponed, and dropped, and what I'll focus on what we adapted later on in the talk. So we decided to continue our summative assessment, and we postponed our formative assessment and dropped entirely our trainee interprofessional simulation. And what I'd like to discuss is, given the sudden absence of clinical exposure for our trainees, we were on lockdown and doing life and limb procedures only. Why did we choose to continue our summative assessment and postpone and drop all formative aspects of our assessment? And to understand this, I think I need to explain a little bit of the context of our training program. We transitioned to a competency-based residency training program in 2015, 2 years ahead of the national cohort. One of the backbones of competency-based medical education is a multimodal frequent assessment. An assessment in CBD, it can be supplemented by simulation, which sits at a much higher level of the shows how aspects of Miller's pyramid. So since 2015, we have integrated simulation-based summative assessment of competence into our program as a way of providing robust assessment data to our competence committee. And our competence committee depends on this robust data to be able to make promotion decisions for our residents as to whether or not they can be promoted along in their stage of training. Put another way, let's review some of the tenets of a robust assessment program. And here it's indicated by the CARVE mnemonic. So C stands for cost effectiveness. Any assessment modality needs to consider the related costs, practicality, and feasibility. We need to look at the cohesion of these different assessments as to how they are used in the program, and the comprehensiveness to make sure that we're covering all the different relevant competencies in the assessment program. The assessment itself needs to be acceptable to the trainees, to our specialty, to our certification body, and to society itself at large. And of course, the consistency of the decisions, or the reliability, needs to be very high. And we need to ensure that these assessments are valid or measure what it's intended to measure. And finally, we know that assessment drives learning. So it's important to make sure that the assessment itself is worth learning towards. The learners improve by preparing for the assessments and from the feedback provided, and it provides a subsequent catalytic effect to improve our educational systems. And I adapted this table from Norcini's Consensus Framework for Good Assessment to show you the relative importance of these different aspects of good assessment with respect to formative and summative assessment. And in looking at this table, and given that we were hoping that the lockdowns and the pandemic impact would be short term, it was clear in our eyes that summative assessment would be prioritized in our program. So we postponed our formative assessments. This, for us, meant our weekly PGY 2 to 5 simulation sessions. We dropped completely our interprofessional participation in our simulations because normally at least 2/3 of our sim sessions are run with our surgical residents, our operating room nurses, and our anesthesia assistants. And what we decided to continue were our summative assessments. For us, this meant our very junior PGY1 Foundation OSCE exam and our Crisis Resource Management OSCE exam. We have unexpected ACLS competency assessments throughout PGY 1 to 2 several times a year. And we continued with our CANASC, or the Canadian National Anesthesia Simulation Curriculum assessments of competence. Now, these are certification requirements for the Royal College, and we needed to continue those in order to allow our residents to be certified by the Royal College. So what did we adapt? Well, we adapted our scenario implementation and our debriefing principles. And to provide some context to this discussion, I'll just outline the impact that the pandemic had on our simulation center operations. So in spring of 2020, the Sim Center was put on immediate lockdown. We were closed for business. We did continue with we initiated some urgent in situ pandemic readiness training, as I've already described. We continued a lot of our training online. So our junior PGY1 bootcamp training sessions continued online. Many of our teaching sessions continued online. And we had instant adoption of virtual immersive simulation videos, as I've already described. Over the summer and the fall of 2020, we did reopen our simulation center, but with physical distancing principles in place. And we needed to be incredibly inflexible, which I'll describe in a few moments. We switched to virtual debriefing education for our simulation fellows, which I'll also describe. And it highlighted the flexibility required and the constant pivoting required a great number of educators to force us to prioritize and trim down our curriculum. In the winter of 2020, leading into the spring of 2021, our simulation center, our entire sim center, was seconded by public health as it became Ottawa's only vaccination center in the city. And that occurred until March 2021 when they started opening other centers. So we were pushed down to the basement of the simulation center. We had only 2 rooms. We had no cameras, no control room. Our debriefing was held basically in a large closet. Fortunately, we were able to run our assessment sessions in the basement with no recordings due to our highly adaptable and flexible learners. In summer 2021, our simulation center continued as a vaccination center until August of 2021. And finally, we were back in our usual space at that point in time. And this fall, we've continued to run our sim center with continued modified numbers and capacity. We've resumed our interprofessional simulation. However, due to staffing issues, it's been difficult to be able to ensure participation of our operating room nurses.
So due to the loss in clinical exposure for our residents, we strongly advocated for simulation training in the midst of the time when the hospital and public health would not even allow us to physically be in a conference room together. What we did, when we did eventually offer to do our formative simulation again, the one word that comes to mind is flexibility. We had rapid increases and decreases in our staffing due to contact tracing and need for self-isolation. We needed to write scenarios that would flex with changes in our participants. are in need to incorporate COVID protocols for IPAC and AGMPs, changes in protocols for managing cardiac arrests, and include goals of care discussions, which were becoming more and more important. We also needed to really focus on our pre-brief, where we reinforced the fiction contract for our trainees, where we emphasized the need to suspend disbelief and to preview what could be expected. We gave reassurance for IPAC concerns and physical safety, and importantly, we needed to address all aspects of realism, both physical, conceptual, emotional, and sociological. These are all outlined in these two papers you see on the right. And essentially, our physical realism was lost. We were now running scenarios in a room that didn't look anything like a clinical environment. We were physically in the room with the participants rather than being hidden from view in the control room. Emotional realism was actually heightened given the concerns about managing airways and self-infection. We found that influenced how people interpreted or sort of experienced our simulation. And sociological realism was in jeopardy because we no longer were able to provide interprofessional simulation. Our nurses were working full tilt in the operating rooms and were unable to leave to come and be in the simulation center with us. In terms of the debriefing adapting, we actually needed to then pre-brief our debrief to include acknowledging physical safety requirements, reinforcing the changes in realism, as I've already described. Wellness checks within our debrief became a regular part of debriefing. And finally, our foundational elements of applied simulation theory, or FEAST curriculum, which we deliver to our simulation fellows, went completely virtual. And it's one thing to give talks and have webinars on topics, but how to actually teach how to debrief and how to teach debriefing the debriefer virtually was something that we needed to adapt. And our current simulation fellow, Dr. Faisal Al-Ghalib, is from Saudi Arabia, and he was a participant in all of this and hopefully can bring back some of this experience when he returns home. So we moved our fellow training online, and we're still doing this now. We were planning on moving everything back in, but then the Omicron variant surfaced last week. And we have the distinct pleasure of, in Ottawa, being the site where it was first detected in Canada. And the daily headlines, as you can see here, are exploding, and it looks like we may be bracing ourselves for another COVID storm. So in this sort of environment, I think it's really critical that we look to our successes and we remember the challenges that we overcame. In terms of successes, faculty simulation-based continuing professional development were prioritized for the first time over trainee education, and there was huge uptake by clinicians. It strengthened our community of practice. Our skeptics bought in completely, and they saw value. Well, especially our hospital senior leadership, which I don't mean to imply that they were skeptics, but they definitely saw value in what we were doing. We empowered our faculty to be PPE champions, teaching each other. We created virtual reality videos for continued learning by ourselves and for the public. And we were able to justify and continue our high quality simulation assessments with very little loss in our formative sim program. Our wellness checks are now routine as part of our simulation, which I think is a big positive. And some of the challenges that we remember that we needed to overcome was realizing the physical risks of COVID transmission during mass delivery of simulation, and needing to keep in mind physical safety within our simulation scenario environment, which helps to also translate to keeping these things in mind when we practice our clinical care. We recognize that there's educator fatigue and burnout with the constant scenario revisions and the flexibility in implementation, and we need to keep that top of mind. And the virtual teaching on how to debrief was definitely a challenge, but we are learning how to continually improve in this area. So over the last half hour, I've described all of how the framework for making choices and sacrifices in medical education during a pandemic, and I've explained the application of this framework within the context of simulation-based education. And I hope you've been able to see some of the successes and challenges we've encountered while delivering our programs in the context of this pandemic. The pandemic has brought into clear focus the underlying rationale and fundamental advantages for simulation based education. And seeing as the origins of simulation based education were in crisis resource management, what I'll leave you with is what Bill George, the former CEO of Medtronic, who wrote in his Wall Street Journal article, 7 Lessons for Leading in Crisis. Never waste a good crisis. When things are going well, people resist major changes or try to get by with minor adaptations. A crisis provides the leader with a platform to get things done that were required anyway and involves the sense of urgency to accelerate their implementation. And with that, thank you very much, and I look forward to your questions.